Okay, good afternoon and welcome to this lecture. This particular lecture will be on cardiovascular physiology. This module aims to provide some of the key physiological knowledge required to use advanced cardiac monitoring in clinical practice. And key topics covered in this module will include circulatory function, particularly looking at pressure and flow physiology. We'll be looking at oxygen delivery in terms of content and transport, and trying to understand some of the key concepts that affect cardiac output, and that will be preload, afterload, and contractility. The heart is a very clever organ. It modulates cardiovascular function to meet the metabolic demands and the needs of the body, so that depending on the situation, for example, exercise or major surgery that we're interested in, which require the body to produce either more or less energy in the form of ATP and to transport nutrients to and from the tissues. This function requires two different physiological objectives to be achieved. The first one is to provide an adequate perfusion pressure in order to force blood into the capillaries of the organs. And tissue perfusion we can very simply define as the input pressure, and that's the pressure at the arterial end. Take away the resistance, so pressure at the venous end. Secondly, we have to provide an adequate cardiac output or adequate flow. And this is to deliver oxygen and substrates to the tissues, and that is the organs essentially. The heart is a very clever organ. It's a source of both pressure and flow, both at the same time. Managing perfusion, both in terms of adequate pressure and adequate flow, requires a frequent monitoring of arterial pressure and cardiac output, and the ability to differentiate between the different causes of hypotension and the different causes of inadequate oxygen delivery. The cardiovascular system's main priority is to maintain oxygen homeostasis, so that oxygen delivery to the cells is always equal or greater to that of the demand. But oxygen demand varies from time to time, and the cardiovascular system has to adapt to these changing demands as time progresses. And it regulates oxygen delivery, increasing it when we're stressed, decreasing it when we're more relaxed. Oxygen delivery, or DO2, is expressed as the cardiac output measured in litres per minute multiplied by the oxygen content of the blood. Now, the oxygen content of the blood is determined by the hemoglobin concentration and arterial oxygen saturations multiplied by a small number, 1.36, which represents the amount of oxygen dissolved, or bound rather, per gram of hemoglobin. This value is measured in mils of oxygen per litre of blood, and normal values for arterial oxygen concentration of blood would be around about 200 mils per litre. Now, if we assume a normal cardiac output of approximately 5 litres per minute for a healthy adult and an oxygen content of 200 mils per litre, then we can see that oxygen delivery is around about 1,000 mils per minute. Oxygen delivery is frequently indexed for body surface area, so we can have a meaningful comparison between different individuals. In normal physiology, however, there is an excess of oxygen supply over demand, providing a safety margin for us as organisms. The manipulation of oxygen delivery is primarily through changes in our cardiac output. Cardiac output is defined as the amount of blood ejected from the left ventricle in 1 minute and is universally measured in litres per minute. And it's often, again, indexed a bit like DO2 for body surface area for clinical application. Cardiac output is the product of stroke volume and our heart rate. And the stroke volume is the amount of blood that the left ventricle ejects in a single contraction. And an average 70 kilo man, it's around about 70 mils per minute. There are three main determinants of stroke volume, and they are preload, which can be thought of as ventricular filling, contractility, which is the force that the heart contracts to expel that blood, and afterload, which is the resistance the ventricle sees when the aortic valve opens. Consideration of preload, afterload, contractility allows us as doctors to manipulate the stroke volume in order to enhance oxygen delivery when this is required. One key part of hemodynamic optimization is trying to match oxygen consumption to delivery through the manipulation or changing or the treatment of these different parameters. In this section, we'll focus on preload in terms of its importance to stroke volume and cardiac output. And we'll examine how changing preload will directly affect our cardiac output, and the importance of venous return, and a relatively new concept called mean systemic filling pressure. Preload is defined as the tension of the myocardial fibers at the end of diastole. Figuratively, this concept, it can't be measured. So we often interpret it as the volume of the blood filling the left ventricle, so our left ventricular end diastolic volume, but it's actually related to the degree of stress exerted by this volume, and the ensuing cardiac sarcomere length. Preload is affected by a number of factors, including venous return, blood volume, and our right atrial pressure, amongst other things, and we optimize preload through giving fluid therapy, and that can be either crystalloid, colloids, or blood products. As preload increases, so does our stroke volume, and clinically our aim is to achieve optimal preload in order to create effective cardiac output. The relationship between preload and stroke volume is defined by the Frank-Starling curve. Now, Starling's law states the force of myocardial contraction is directly proportional to the initial fiber length. And this means that when the volume in the ventricle at the end of diastole is increased, the tension of the myocardial fibers is also increased, and consequently, the stroke volume rises. The effects of this can be seen by administering a fluid bolus. Here's a point on the lower end of the Frank-Starling curve, and as we give fluid, so we increase our preload, we stretch our myocardial fibers and stroke volume increases. If we have a rise of 10% in our stroke volume, then we define that person as a fluid responser, and that is they're on the steep part of the Starling curve. However, as we see at this endpoint here, if we give too much fluid, we overstretch those fibers and they no longer become efficient, so stroke volume starts to decline. Now we can see the effect of increased preload if we look at a left ventricular pressure volume curve. We measure pressure in the left ventricle and at the same time measure the volume in the ventricle as well. Now, a normal ventricle fills in diastole, and we can see here that the volume in the ventricle increases, causing a relatively small increase in LV pressure. And this is because the ventricle is quite compliant, so that volume doesn't stretch it too much, and the pressure change is minimum. The ventricle then contracts, and this is isovolumetric contraction. So the left ventricle is squeezing against a closed aortic valve. The volume's not changing because that valve hasn't opened yet, but pressure's going up. Once pressure in the ventricle equals or is greater than the pressure in the aorta, the valve opens and the contents of the ventricle are expelled into the circulation. And that's what we see here. And then the heart relaxes once again, coming back down to normal. The difference between the end diastolic volume and the end systolic volume is our stroke volume. And we can see this as the width of the pressure volume curve here. When we increase preload, we're increasing the amount of blood that fills during diastole. So our end diastolic volume is greater. This means that the heart then injects more blood that is present in the ventricle and stroke volume is increased. And this increase in stroke volume is displayed as an increase in the width of the pressure volume loop. One of the ways that we increase our preload is by increasing venous return. And venous return is a key component of our cardiac output. Very simply, venous return is defined by the mean systemic pressure, that is the driving pressure taking blood back to the right side of the heart, minus right atrial pressure, which is the resistance to blood flow to the right atrium. And we divide this by our resistance to venous return. Mean systemic pressure is a rather unusual concept that is actually rarely discussed in cardiovascular physiology, but it's key and essential because, as we've seen, it's the driving pressure that takes blood to the right side of the heart. Mean systemic pressure is the pressure in the vascular system if the heart stops and the pressure redistributes. It's determined by the volume that distends all the elastic structures and the sum of all their individual compliances. Now, in healthy individuals, it's approximately 7 to 8 millimeters of mercury, and it's an indicator of how full the system or the circulation is. And that is, it's the relationship between blood volume and the total capacity of the system. So, as we mentioned, it's the driving pressure or input pressure for venous return. It's affected by blood volume and vasomotor tone. These are the static determinants of MSP, and blood flow distribution and venous conductance of the dynamic determinants. So mean systemic filling pressure or mean systemic pressure will increase if there's an increase in blood volume or a decrease in venous compliance. And hence, assuming that right atrial pressure remains unchanged, then the venous return will be improved. Conversely, mean systemic pressure will decrease if blood volume is decreased, such as in hemorrhage, for example, or if venous compliance is increased through the use of various drugs. And these situations will both lead to a decrease in venous return. Venous return is important because essentially it is the cardiac output. The heart can only eject what's returned to it. So mean systemic pressure is a driving pressure for venous return, returning blood to the right atrium, and hence the right atrial pressure or central venous pressure is the resistance to this flow. It's not a measure of how full we are. What the heart does is to regulate right atrial pressure, which in turn alters our venous return, which in turn alters our ventricular filling, and therefore our cardiac output. The two most commonly used measures of, or methods of measuring preload are the direct measurements of central venous pressure and pulmonary artery pressure through catheter-based techniques. For many years, these have been the mainstay of determining fluid status for patients and individuals, particularly in those who are critically unwell. However, the assumptions that these methods make are ultimately flawed, and these measurements do not provide an accurate measurement of fluid status. Central venous pressure, or CVP, is a measurement of pressure in the vena cava close to the right atrium. It's been typically used by clinicians in the assessment of intravascular volume for many, many years, and the assumption is that your right atrial pressure is equal to your right ventricular preload, which in terms relates to your left ventricular preload also, and hence therefore your position on the Starling curve. The assumption that CVP equates to left ventricular end-diastolic volume is however incorrect, and this is because the assumption ignores the impact of vasomotor tone, left ventricular compliance, right ventricular compliance, and ventricular geometry, amongst other things. In addition, as we have discussed previously, it's not right atrial pressure that is a measure of venous return or filling. This is the resistance to flow coming back to the heart. It's the pressure gradient between mean systemic pressure and the right atrium that determines venous return, and hence our cardiac output. If we move on to the measurements of pulmonary artery pressure, then as a means to assess volume status, it has the same issues as CVP, and to be honest, if not entirely worse. Measurement of a pulmonary artery occlusion pressure requires the insertion of a pulmonary artery catheter, which is wedged into a tapering branch of one of the pulmonary arteries. It can be difficult to measure, as the tip must be placed exactly in West Zones 3. Essentially, in using this measurement, or this method to estimate blood volume and status, the underlying assumption is that pulmonary artery wedge pressure estimates our left ventricular end diastolic pressure and hence our volume. And this assumption is ultimately flawed. But even assuming that's correct in normal physiology, there are a number of situations where this relationship is disrupted, such as in mitral stenosis, left ventricular failure, aortic regurg, and pulmonary venous obstruction, amongst others. We make a number of assumptions when using pulmonary artery occlusion pressure, and not just that pulmonary artery wedge pressure estimates left ventricular end diastolic pressure and hence our volume. We first assume that pulmonary artery occlusion pressure is approximate to pulmonary venous pressure. And then what we do is assume this is approximate to left atrial pressure, which in turn is proportional to left ventricular end diastolic pressure, which in turn is then proportional to left ventricular end diastolic volume. This is a significant number of assumptions to make. However, the most inaccurate assumption is that left ventricular end diastolic pressure equates to left ventricular end diastolic volume. And the assumption that left ventricular end diastolic pressure is proportional to its volume is a rather dangerous one to make, because the normal left ventricular end diastolic or ventricular pressure volume curve is curvilinear. In addition, the relationship changes depending on ventricular compliance. For the same pulmonary artery occlusion pressure, if the left ventricle has a low compliance compared to a normal ventricle, then the volume in the poorly compliant ventricle is reduced, and hence the filling status is overestimated. Conversely, for the same pulmonary artery occlusion pressure, if the left ventricle has a higher compliance, then the volume in the compliant ventricle is larger, and hence the filling status is underestimated. So once again, this parameter doesn't help us decide filling status, nor does it help us decide if that subject is going to be fluid responsive. Newer methods of determining a subject is fluid responsive are now being used in clinical practice, with the two most commonly used variables being stroke volume variation and pulse pressure variation, and these rely on the changes in venous return and afterload due to mechanical ventilation, which cause stroke volume and pulse pressure to change over this measured cycle. These changes can be thought of as repeated mini fluid challenges and hence can determine if patients are fluid responsive or not. The second determinant of stroke volume is contractility. Cardiac contractility, very simply, can be defined as the tension developed and the velocity of shortening of myocardial fibers at any given preload. It resembles a unique and intrinsic ability of cardiac muscle to generate a force that is independent of any load or stretch that is applied. Factors that increase contractility and hence have a positive inotropic effect include activation of our sympathetic nervous system, circulating natural catecholamines, and various medications that include deduction and adrenaline. Factors that decrease contractility and hence have a negative inotropic effect include the parasympathetic nervous supply and various medications that depress the myocardium, including many anesthetic agents that we use in today's practice. If we look at our normal pressure volume loop, we can see how either increasing or decreasing contractility changes these loops and hence our stroke volume. If we increase contractility, we can see the ventricle generates a higher pressure, and also the rate of pressure development is also greater. This leads to a decrease in the end systolic volume, meaning the left ventricle has ejected more blood and the stroke volume is higher. Because there is less blood in the ventricle at the end of systole, the ventricle fills to a slightly smaller end diastolic volume, but overall stroke volume, which is the width of the curve, is increased. Conversely, if contractility is decreased, the ventricle generates a lower pressure, ejecting less blood, and hence the volume at the end of contraction, so our end systolic volume, is lower, and the stroke volume has decreased. Changes in contractility can also be demonstrated on the Frank-Starling curve. An increase in contractility shifts the curve up, demonstrating that increase in contractility improves stroke volume. The curve that demonstrates a decrease in contractility is shifted down and laterally. And therefore, for any given left ventricular end diastolic pressure, stroke volume drops with decreased contractility and increases with improved contractility. Once again, going back to our our pressure volume curves, one of the accepted measurements of contractility is the slope of the end systolic pressure volume relationship. The maximal pressure that can be developed by the ventricle at any given left ventricular end diastolic volume is defined by the end systolic pressure volume relationship. If we draw repeated curves, or repeated pressure volume curves rather, for the same ventricle where contractility and afterload remain a constant, however only preload changes, then it's a line that connects the points at the end of systole and is called the end systolic pressure volume relationship. The gradient of the ESPVR represents contractility and is called end systolic elastance. Essentially, ESPVR becomes steeper and moves to the left as contractility increases, and it becomes flatter and moves to the right as contractility decreases. An alternative measure of contractility is the maximum change in pressure over time of the left ventricular pressure during contraction, also known as dP/dt. That is delta pressure, dP, divided by delta time, dt. In clinical practice, the maximal dP/dt of the systolic slope of the arterial pressure waveform in a conduit artery, so such as the radius, can be used as an indicator or measure of contractility. And this correlates with end systolic elastance. The steeper the slope, the quicker the rise in pressure over time, and hence the greater the dP/dt, and hence the stronger the contractility. The shallower the slope or slower the rise of dP/dt, the weaker the contractility. So here we have an arterial waveform with a high dP/dt, so very quick pressure change over time, which represents our good contraction, compared to one with a low dP/dt, which represents poor contractility. So the final determinant of stroke volume is afterload. And when understanding how the heart interacts with blood vessels to generate flow, it's essential to understand the arterial load. That is essentially the opposition. And that must be overcome by the ventricle to eject blood into the aorta. Arterial load represents all the non-cardiac factors that resist blood flow, and therefore we can think of it as a net measurement of our afterload. Afterload is increased by peripheral vascular resistance, by high elastance of our major blood vessels, ventricular dilatation, and an increase in ventricular pressure and negative interthoracic pressure. Conversely, it's reduced through reduction in our peripheral vascular resistance, good compliance of our major blood vessels, and decreased ventricular pressures and increased ventricular wall thickness. Decreasing afterload can decrease stroke volume, and this can be achieved in the clinical environment through reduction in vascular resistance. Traditionally, systemic vascular resistance has been used to characterize the arterial system and obtain a gross simplification of afterload. It's calculated by computing the difference between our mean arterial pressure and our right atrial pressure, and is divided by the cardiac output, and the whole equation is multiplied by 80. Measured in dyne seconds per centimeter to the -5, with a normal value being between 800 to 1200. But once again, unlike oxygen delivery, this can be indexed for body surface area. We can see how changing afterload affects our stroke volume. Here's our original pressure volume curve here. If we decrease afterload, there is less resistance to blood being ejected from the ventricle, so it needs to generate less pressure before the aortic valve opens. And in addition, the velocity of the cardiac muscle fiber shortening is increased, leading to an increased ejection velocity, more blood being injected, and hence a decreased end systolic volume. This in turn leads to a greater stroke volume. If afterload increased, however, the opposite happens, with the ventricle having to generate a much higher pressure to open the aortic valve, and it's met with greater resistance. Decreased muscle fiber shortening reduces ejection velocity, and we end up with an increased end systolic volume, and hence a decreased stroke volume overall. In terms of measuring arterial load, it can be characterized into a single number, which is called effective elastance. And this is the ratio of the end systolic pressure divided by our stroke volume. We can show this by the line seen here on the PV curve, and essentially the higher and the steeper the line, the increase the afterload, the lower the line with the reduced gradient, the less the afterload. We can see the importance and the interaction of venous return, because if we draw the venous return curve, then where our cardiac contractility curve, that is the Starling curve, intersects, then this is the equilibrium point on our cardiac output at any one point in time. So cardiac function is determined by the intersection of the venous return function and the cardiac function. When we give a fluid bolus, we increase our mean systemic pressure, therefore increasing the driving pressure, and hence venous return, and we change this equilibrium point, increasing our cardiac output. If we lose volume, then the opposite occurs. So in summary, cardiac output is affected by preload, afterload, and contractility. And the interaction of these variables are complex. Understanding the relationship of these variables and how they can be manipulated allows the clinician to alter oxygen delivery to meet the patient's needs, and is key in being able to manage a patient's hemodynamics. Thank you.